Good afternoon. Welcome to the Stroudwater Associates Partnership Institute. We're grateful that you've chosen to spend your time with us today and to join a community of leaders who are deeply committed to the future of rural healthcare. For more than 40 years, Stroudwater Associates has focused exclusively on supporting rural and community hospitals. Our work sits at the intersection of strategy, finance, operations, and partnerships, helping hospitals navigate complexity while protecting access to care in the communities they serve. Many of our consultants are former hospital executives and operators themselves, so we understand firsthand the realities you're facing. Today's Institute is designed to be practical, candid, and forward-looking. We'll explore a series of sessions that reflect the real decisions rural hospital leaders like yourselves are confronting right now, including strategic risk and rural hospital closure, evaluating risk in your hospital's trajectory, performance improvement and strategic options, key considerations and success factors, protecting and securing the value of rural partnerships, key considerations for county and district-owned hospitals, and the role of partnerships and restructuring for rural hospitals. Then we'll conclude with final takeaways to help translate today's discussion into action. Throughout the day, you'll hear from Stroudwater leaders and trusted partners who bring deep experience in rural strategy, finance, operations, legal considerations, and partnerships. Here's a bit more about them. Julie Georgioff. Julie's a consultant at Stroudwater Associates with deep experience in healthcare finance and operations. A former critical access hospital CFO, she supports rural hospitals through financial and operational analysis, strategic planning, service line evaluation, and revenue cycle improvement, with a focus on building sustainable, community-based care models. Jeff Summer. Jeff is the managing director, the supreme emperor at Stroudwater Associates, and brings more than 25 years of experience advising community hospitals on strategic planning, capital planning, affiliations, and partnerships. His work focuses on helping organizations evaluate strategic options and execute complex initiatives that strengthen long-term access to care. Wade Gallen. Wade Gallen is a senior consultant at Stroudwater Associates with expertise in reimbursement, cost reporting, and financial analysis for both critical access and acute care hospitals. He supports hospitals in navigating complex reimbursement environments and improving financial performance through data-driven insights. Claire Kelly. Claire is a senior consultant at Stroudwater Associates as well, specializing in affiliations, partnerships, physician strategy, and rural hospital planning. Her work includes risk analysis, strategic planning, joint ventures, and helping larger systems understand and partner effectively with critical access hospitals. Trent Krenke. Trent is a member at Reed Clayman and is board certified in health law. He advises hospitals and healthcare providers on regulatory compliance, healthcare transactions, and operational matters with extensive experience supporting rural hospitals through complex partnership and compliance considerations. Jennifer Lyday. Jennifer is a partner at Waldrop Wall Babcock Bailey PLLC and focuses on healthcare restructuring, bankruptcy, and complex healthcare transactions. She advises hospitals and healthcare organizations on legal strategies related to financial distress, restructuring, and partnership transitions. My name is John Downs. I'll be the moderator for today's session. And with that, let's begin.
Thank you, JD. I'm here with Julie Georgioff, and Julie and I will be sharing with you some of the findings from our analysis of rural hospital closures, specifically really looking at the trajectory prior to closure and how strategic risk manifests itself differently for rural hospitals that happen to close. And this is an examination of industry experience from 2010 to 2024. Our contact information, and again, we're pleased to be with you and thank you for joining us. Let's get to the substance. First, we'd like to start by acknowledging this work began more than a year ago And in earnest, when we had a conversation with the folks from the North Carolina Rural Health Research Program, specifically George Pink and Tyler Malone, who had done a great deal of work analyzing rural hospitals that closed. And so this work owes a debt of gratitude to those individuals who did that research, but in particular, their initial thoughts on helping to shape our work. There is a bibliography that's attached to the back of this slide deck should folks want to do any additional reading on rural hospital closures. So starting off, we had a hypothesis that the trajectory to rural hospitals closing was unique from those that remained open. And the data has really validated that. This is an examination of operating cash flow margin, and you can see the dark bars is actually the 25th percentile of those that closed. So the lowest quartile of those that closed, looking at their cash flow margin. The lighter bar is the 75th percentile. So the top quartile cash flow margin of those hospitals that closed. And you can see that top quartile actually performed fairly well for a long period of time leading to closure with the median. That's the gold line there for the open hospitals, the rural hospitals that did not close. But you can start to see beginning in what we've labeled as year -4. Those are the numbers across the bottom. That's 4 years prior to closure. And looking at year -4, then year -3, -2, -1, you can see that there is a falling off, not just of the top quartile of rural hospitals that closed, but also that dark blue line, which is the median for all rural hospitals that closed. And so one of the things that Julie and I want you to focus on is the 5 year between years -8 and -4, because this is the period of time, given the lagging, the availability of data and the time lag when that data is available, we believe that hospital leaders really need to focus on the trajectory of the organization. If you start waiting to 2 years prior to closure, given the lagging of available data, you end up with having very little time to execute a turnaround that may alter the trajectory of the organization. But this chart, we'll see many more like it, really does a nice job of setting the table for us as we start thinking about rural hospital closures and how they differ from those hospitals that remained open. In this case, I would point out to you that the compound annual growth rate for the median operating cash flow for closed rural hospitals decreased by 20% on a compound average growth between year -8 and -4. So that gives you a marker at that point for, again, how closed hospitals differ from those that remain open. This is the same chart, but showing total cash flow margin. So this builds in proceeds from perhaps tax support. If there's a local hospital district that has a mill rate that's dedicated towards supporting the local hospital, but also non-operating sources of income, such as return on investments, et cetera. And you can see it's a similar story, although the median for open hospitals does pull away again, year -4 moving forward. And there is a increasing separation between the median for open versus median for close as we move through year -4 and closer to closure. So for total cash flow margin, the compound annual growth rate between years -8, 8 years prior to closure, and year -4, 4 years prior to closure, is a -6%. So again, you can see that the total margin does make a difference, but it's still a significant negative trend. So this concept of a critical action zone, that period between -8 and -4 years, really want folks to focus on that, because we believe as you move closer to year -4, given the time lag of data, you're really going to be making decisions in what is essentially the equivalent of 3 years prior to closure on this typical trajectory for a hospital that is looking at potential future closure. And again, we want to make sure that folks have additional time to take the steps to avert that worst case outcome. And so that's why we emphasize that really trying to be as front running as you can and proactive on taking steps to mitigate risks associated with closure is really important. So the strategic context in all of which this is occurring, we wanted to kind of anchor you in that context. And importantly, I would say that rural hospitals, in our experience, fall into one of these five categories, with the middle three categories representing the vast majority of hospitals. So the desired state, from our perspective, is thriving independence or interdependence. This is, for the most part, a locally governed, locally accountable, thriving healthcare delivery system. Uh, Challenging to do, challenging to have access to the resources and expertise, but certainly something that we do see out in the field. In our opinion, that's an ideal state. The next most ideal state is being in a partnership and working with a good partner. So you may have lost some of that autonomy, some of those decision rights, but that partnership is creating value and recognizing the value of that rural community, that rural affiliate when they're making decisions. Um, those are the two best case scenarios. You get to a middle state, which we call strategic drift or kind of purgatory. And again, this is a really critical point. You want to be not moving to the left and not having a degraded operating results or heightened strategic risk if you're in this category. You want to be taking those steps to minimize risk and moving towards thriving independence, being in the upper quartile or half of this center category to minimize the likelihood that you face one of the two worst outcomes that we see, and one of those being a bad partnership, a partnership that really doesn't work well for the rural affiliate, that is perhaps in some respects predatory, but certainly doesn't recognize the value. And when they're evaluating the performance of rural affiliates, is really getting it wrong. And the worst case outcome being closure. And that's what we're going to spend our time talking about today. The reason we want to focus on that year -8 to -4 is those hospitals would be most likely to be categorized in this strategic drift category. And so what can be done to ensure that those hospitals don't move into one of those two categories to the left and are hopefully moving towards the better outcomes to the right-hand side of this continuum. And you can see the tale of woe here, 200 closed or converted hospitals around the country since 2010. This chart has a lot of information. Certainly, we see a spike in closures in 23 and 24 post-pandemic as all of those effects came to rue. But this had been going on for a while. There's certainly geographic concentration that you see there, but this is something, again, seem to have lost our slides.
I'm working on it. I don't know what happened.
Julie, I can share from my deck if that helps.
That would be great.
Okay.
It won't let me do anything.
Okay. Just get back to where we were. There we are. So again, something to keep our eye on. This is not an isolated outcome. This is a major adverse milestone for these communities that go through this. So we are looking at some of those key indicators of strategic risk. And based upon the research we've done and that Julie and I will share with you, top line revenue, both the magnitude, the scale of the organization, and the trajectory. Is top line revenue growing sufficiently? Overall operating performance, looking at margins and cash flow. Liquidity, certainly as a measure of organizational resiliency. Fund balance, also a measure of organizational resiliency. Market share. We see notable differences in market share and market share trend between open and closed rural hospitals. There certainly are characteristics of the market, the size of the market, median household income and poverty rate, all of which elevate the relative risk of an organization and the challenges it might face going forward. And so certainly the last category being hospital characteristics, critical access versus an acute care prospective payment system, we've abbreviated here as PPS, with PPS having a greater risk of closure at a given level of revenue than a critical access hospital. Critical access hospitals can, because of the nature of that reimbursement, can be sustainable at a smaller scale than a prospective payment hospital, which doesn't benefit from cost-based reimbursement. So this is a chart here that basically looks at the impacts of the one big beautiful bill and how its impact on eroding hospital margins. So this is obviously an estimate, but the estimate is that 20%, 21% of Medicaid funding is at risk and likely will be reduced. And so cash flow margins being cut nearly in half, creating significant financial pressure. So you see the dark blue line is current median total cash flow rates over this time period. And then you see a comparison of what that looks like. This is for the open hospitals then, with the One Big Beautiful Act, and put in context alongside the median for closed hospitals. So the One Big Beautiful Act is going to, without appropriate counter steps on its own, create a significant additional impact risk factor for rural hospitals going forward. So one of the points we'll emphasize, and you'll see this theme crop up in several of these talks today, is the importance and centrality of risk mitigation. And the most important lever for risk mitigation being improved operating performance. These are the results of 30 different performance improvement projects that we conducted on rural hospitals over a 2.5 year period. And the point of showing this to you all is really just to emphasize that there is a pathway and there are approaches to performance improvement that are relevant to rural hospitals and that have had very significant material benefits to those organizations. So as you can see on the right and that bar chart, the horizontal bar chart, there's a myriad of opportunities that we've identified working with organizations. Importantly, our emphasis has not been on cost cutting. It's been on trying to recognize opportunities for incremental revenue and growth. And that gets back to one of those key risk factors I alluded to before, which is organizational size or scope as measured by net patient service revenue and the trend or growth rate of net patient service revenue. And so you can see the impact. Again, rural hospitals vary so much in scale. The dollar amounts can be skewed. I think it's maybe more relevant to look at the percent impact as a percentage of net patient service revenue, with median impact being just shy of 8% potential upside and realized upside on net patient service revenue from these activities. Again, a result like this and embarking on a process like this does take time, but can materially change the trajectory and the risk profile of an organization. So we're at our first polling question. And with that, what we'd like to do is ask you to respond to the questions below to get an understanding of how each of you has experienced this. So how would you describe the current risk profile of your hospital, ranging from high risk to elevated risk, moderate risk to low risk? We'll take a few minutes to gather results. Give it another second or two. Terrific. I'm going to end the poll there and share the results. And you can see a little under 20% describe themselves as having a high risk, high strategic risk relative to their risk profile. Elevated risk is a little north of 20%, moderate risk about a third, and low risk being a quarter of organizations. So a fairly even split, with the most common response being moderate risk, and closely between elevated and low risk, and the least common at about 18% being high risk. So an interesting distribution of risk there. Okay, Julie, do you want me to continue, or would you like to continue?
As long as you can hear me, I am ready to go.
Great, we can hear you.
Wonderful. So let's dive into some of the data that we've really learned from in this closure study, and that has been just eye-opening to some degree. As you can see this chart here, the gold line is open rural hospitals medium net patient service revenue, and the blue line is median for closed, and then the two bars kind of give you a feel for the 25th and the 75th percentile. And as you can see, open hospitals generate between 52 and 63 million in net patient service revenue, which is substantially more than the closed hospitals that you see down below in the 10 to 11 million range. Open hospitals show an incline as they grow their net patient service revenue, and they grow that annually by about 2%. Whereas closed hospitals, they see a net patient service revenue decline between 3 and 8%, and that's including these blue bars at the bottom. We've learned that this growth is a substantial differentiator. And it's demonstrated by open hospitals as we studied and began to understand the trajectory to hospital closure. The lack of growth in net patient service revenue is consistent for closed hospitals, and it led us to begin to focus on that critical action zone, that shaded area of -4 to -8 prior to closure that Jeff mentioned. This time frame allows us to provide data to hospitals with time to monitor and improve revenue or operations in general before the financial challenges become unsurmountable. So that's a lot of why we focused on these years, is that performance becomes key around what we're able to do and how we're able to impact the risk of closure in general. We looked at net patient service revenue and broke it down by critical access hospitals versus PPS hospitals to see what we could learn there. And you can see that the closed critical access hospitals, the dark blue bar near the bottom, declined by about 1%, where closed PPS hospitals increased by 1% in that critical action zone. So it's not to say that if you don't grow a little bit, you might still be at risk. It's to what degree do you need to grow to lower your risk. And PPS hospitals growing 1% each year still closed, further indicating the importance of that revenue focus in growth in risk, in reducing your risk for both critical access and PPS hospitals. Open hospital revenue is within range of each other for the critical access and the PPS hospitals as a relative indicator of size, whereas closed hospitals show critical access hospitals of smaller size closed. There's quite a difference there as compared to the PPS hospitals, with critical access hospitals being around $8 million in annual net patient service revenue, and PPS hospitals being nearly twice that. So we also felt that the proportion of open to closed hospitals is substantial for both categories, but a greater difference for critical access hospitals was demonstrated in the data, and that in some ways indicates that critical access hospitals with slower growth are insulated a little bit due to their critical access designation. So let's get into the money. Looking at operating cash flow, which Jeff talked about a little bit, but if we look at the percentage of hospitals, percentage of closed, this is just closed hospitals, nobody's open, just closed. More than half of the closed rural hospitals operate with positive operating cash flow during that critical action zone. And we found that very interesting because one of the things that really popped out to us immediately was the hospitals that were losing money for a very long time versus some that weren't. this chart indicates that positive operating cash flow does not ensure hospital sustainability. So it's important to begin to understand the level of cash flow required to sustain operations and be able to reinvest in your hospital and really sustain the hospital for your community. Operating cash flow is an important indicator of risk of closure, and we wanted to dive into that and look a little bit further. So then one of the things that we did was we took the hospitals that had positive operating cash flow, and we compared that positive operating cash flow to their current liabilities. It's represented here in months, and you can see that again, the mustard or gold colored line is open hospitals, and then the blues below are the closed hospitals. And this represents the number of months that hospitals could sustain, could fund their short-term liabilities with their operating cash flow. You can see that closed hospital median operating margin flow, cash flow generated coverage of short-term operations for less than 6 months if you look at the blue line. And overall for closed hospitals, the metric ranged really a pretty broad range of 1 to 13 months, whereas open hospitals were between 9 and 12 months fairly consistently. So this cash flow consistently can generate a level of operational and strategic resilience to manage working capital, to reduce reliance on debt, and to build the hospital's balance sheet over time, exceeding the operational cash flow of closed hospitals. That trend of being able to rely on a certain level of cash flow certainly was seen as a benefit in lowering your risk of closure. Then again, we broke out critical access hospitals and PPS hospitals to analyze the different abilities to cover short-term obligations. In general, these graphs show a somewhat tighter cash flow model for critical access hospitals, which is to be expected since critical access hospitals are reimbursed on a cost basis. And this also highlights a somewhat defined lack of financial flexibility for critical access hospitals. By nature, they're a little bit smaller, and their cash flow is definitely impacted by that cost report settlement that happens for cost-based reimbursed hospitals. We also see a larger variance trend between open and closed PPS hospitals than critical access hospitals due to their model of outpatient prospective payment reimbursement and inpatient. And this is because, as we would expect higher current liabilities for PPS hospitals due to their inherent size difference compared to critical access hospitals being 25 beds or less. So operating cash flow remains important for both types of hospitals, but it does vary to some degree based on the designation of critical access versus not. So then we looked at, for hospitals with negative cash flow, what is the run rate in months that they can sustain with utilizing their reserves without depleting their reserves? And if we focus on the shaded critical action zone that Jeff mentioned, closed hospitals showed a wide range of between 0 months and 31 months, with a median of 5 to 8 months before cash is depleted. Median cash run rate for open hospitals, on the other hand, was always over 30 and ran from 30 to 34 months. Again, you see a little bit more of that consistency as well. It's a substantially longer run rate for these median open hospitals than you see for the closed hospitals. Metrics such as cash run rate they're key to monitoring hospital performance and utilizing benchmark data to compare yourself to others. I often encourage rural hospital leaders to actively monitor and manage their cash flow levels over time, to watch for gradual changes and really see the trends that might be coming around the corner. So let's talk a little bit about the market characteristics of these hospitals. We looked at market share, and we define a hospital service area by selecting the contiguous zip codes required to reach 75% of hospitals' Medicare cases. So we did this for each rural hospital in the country and to calculate market share for open and closed rural hospitals individually. And then we calculated those to the medians that we've been talking about in the 25th and 75th percentile. There's a noticeable 14% variance that increases to a 17% variance between the gold line and the navy blue line, the market share overall, the medians for open and closed. You clearly see in this graph a declining market share for closed hospitals, with open hospitals declining slightly, but not to the degree that we see for the closed hospitals. So closed rural hospital market share consistently declines by an average of 7% over the 10 years that we looked at, whereas open hospitals declined an average of 2%. So that's quite a bit of difference. It indicates for us that market share retention and growth of market share, those are factors that can help to reduce the risk of hospital closure. Whoops. There we go.
Did I skip something?
There we go. We're getting there. So then we also broke that out for critical access hospitals as compared to PPS hospitals. Open hospitals for both cohorts are similar with modest declines in market share, where closed hospitals demonstrate a lower market share overall for critical access hospitals. Again, to some degree, based on the models, that's to be expected. But for both cohorts, market share dropped by nearly half, validating that market share trends do impact the risk of closure. So median market share for closed PPS and critical access hospitals is lower in general and decreasing at a faster rate than median market share for open hospitals. Okay, so let's go with our second polling question if we could. The question is, how significant do you believe the risk is that your hospital may need to close or convert within the next 36 months? Very likely, somewhat unlikely, very unlikely, or you're just unsure. That's not something that you've really thought about. So we'll give you guys a minute to give us some responses. Excellent. Excellent. So if you want to go ahead and close that, we will show you that about 14% seem likely that they are at risk of closure, and 14% seem somewhat likely. So really about a quarter of hospitals believe that it's likely and to some degree that they are at risk of closure, where the unlikely categories is about 2/3 of the hospitals that are joining us today for the call. So we appreciate that, and we appreciate that you guys have given this some thought. And with that, I will hand it back over to Jeff.
Great. Thank you, Julie.
Mm-hmm.
All right. So one of the things we want to leave you with as part of this session is an understanding of how to think about strategic risk. And a key point we would make is when you think about strategic risk, we've divided it into 4 categories. And perhaps the best known categories are the financial risk and operating risk categories, where you think about those metrics and my guess is, and we've spent a lot of time so far talking about some of these, the financial metrics folks know, and some of those operating metrics as well. Where I think it gets into maybe a little more uncharted territory is thinking about, okay, how do market shifts, and these occur obviously over time, but market position is measured by market share and competitive, or the market share of competitors, consumer preferences. How do people perceive your organization? When you look at HCAP scores, you can do well on a number of those categories, but then the likelihood to recommend number, if that's a real lagging indicator and substantially behind folks that have significant market share in your market, that can be a real challenge. Market size being another factor. But this question of value risk, I think, is one that's really important to think about. What are the quality scores? And when we think about value, we're really talking about the interplay of cost or price relative to quality. And so in this case, measures of cost effectiveness or relative cost to alternatives and relative quality to alternatives is hugely important. And then the ability or the capacity to manage or assume risk and also have aligned primary care, which is a huge component of that. All of those are really important. Importantly, risk can spill over from these categories. It's not isolated. The changes on these categories can be fairly modest and maybe not even raise alarms year over year. One of the key things that folks need to do is look at longer trends, 5-year, 7-year trends, to understand, geez, we really have seen a slow, steady erosion of market share or a slow, steady erosion of our quality scores. Really important so that decision makers, leaders, boards, the C-suite understands the cumulative effects of those smaller changes over time and across the risk domains. So key takeaways here. What we've spent time talking about today is what differentiates the experience of hospitals that closed in the years prior to closure versus comparing year to year in the same time frame. So the experience has been normalized to allow for that comparison to open based upon the relative date of closure. How has that experience differed between, again, quartiles of closed hospitals versus the median performance of open? And we've seen very significant variances in market share in both the amount of net patient service revenue, i.e. the size of organizations, but also the growth rate of net patient service revenue, and also operating and total cash flow. We believe total cash flow might be a better variable to describe risk because it captures some of those non-operating factors that are so important to the vitality and sustainability of rural hospitals, like tax support or non-operating revenues such as investment income. So looking at the trend and absolute levels of those metrics over a time period and comparing those to perhaps median or quartile values of closed hospitals versus open, an important consideration and reality check. We also looked at cash flow. This is positive cash flow to current liabilities as a short-term outlook. Again, as a way to look at the subset of rural hospitals that have positive cash flow, how does that position them to address their liabilities going forward and some of the funding needs of the organization? And for those that have negative cash flow, looking at that cash run rate. So you've got negative cash flow at that net rate of negative cash flow. Over how many months would it take to deplete the cash and reserves of the organization? Again, another really significant measure of risk of closure. And again, another one of these where we saw very significant variances between median performance for closed and median performance for open. One of the things that's notable here is the top quartile of hospitals that closed in some of those metrics did approximate the median performance of those that were open. So there is a set of reasonably high performing rural hospitals by these metrics that still did close. So again, this question of strategic risk and closure risk is nuanced, is multifaceted, but it is something that can be monitored over time and really should be monitored over time for smaller changes. So key performance findings. There were, as we stated, differences in performance indicators in that period prior to closure. And we looked at 10 years prior to closure with a focus of the 5-year period between 8 and 4 years prior to closure. Again, the key point there being that by looking at that time period, it enables management and leadership to take action in a timely way to change the trajectory of the organization. Generally speaking, financial challenges became more acute and really started dropping off 4 years prior to closure and then accelerating as the organizations moved closer to closure. So we've dubbed this the critical action zone, that 5-year period between year -8 and -4, or 8 years prior to closure versus 4. And again, significant variances in performance trend And being aware of those benchmarks and trends can help reduce the overall risk of closure if if the organization takes action. So polling question number 3, whoops, is going to be up, and we would love to get your feedback on polling question number 3. Are we going to be able to prompt those questions? Apparently not. Okay. Key lessons. Operational performance is essential to mitigating strategic risk and preserving strategic options. In this case, key consideration is avoiding risk of closure and mitigating risk of closure. Time's never a neutral factor. So the status quo is often, for most organizations, not a viable option. And in this case, it's important that folks understand that the absolute minimum time, in our experience, necessary for the organization to see the full benefits of an operational turnaround is 2 years. There are some strategies and some initiatives, recruiting additional primary care, recruiting a key specialist, that can take more than that time to see the results. All that expense has occurred, the recruitment costs, the ramp up time, et cetera. But until the organization starts seeing the benefits of being able to retain those cases and grow revenue, that can be deferred for some of those things. Other things are much quicker. Looking at cost report related items and being able to file a interim cost report to realize some of those benefits can create results much quicker. So it's a mixed bag, but you need at least 2 years to execute and see the full benefits of all the initiatives available to improve performance. So that timing consideration is key. You need to know your value and risk profile. Risk profiles for risk markers for closure are evident, we believe, 4 years, 5 years prior to closure. And many organizations should be monitoring how they're performing relative to some of those benchmarks. There are no strict risk-free strategic options, but the operating results are essential and really are the best risk mitigating strategy, regardless of whether you're partnering or remaining independent or already in a partnership. Early action saves hospitals. The sooner you alter course, the less drastic the course correction required. So hopefully that's a point we've driven home today. It really is important to be proactive so that your organization can reduce the risks associated with that rapid negative trajectory in the last few years prior to closure. With that, we wanted to thank you all for joining us for this session. It's about 1:45, and I don't know if we have any questions at this point that maybe we could answer, but we'll be adjourning if we have questions with a little bit of time prior to the next session.
Sure. Yeah, Jeff, there are a couple that have popped in, but certainly as anyone else fires in questions, I will read them out to you. And just to be clear, all the answers in the Q&A will be included as part of the follow-up materials. But one question that came in conducting the closure study, what surprised you the most?
Julie, do you want to take a first whack at that?
Yeah, it was great because many of the metrics, when we dug into them, brought us to a surprising level. But I think one that really stuck with me was I was surprised how many hospitals were operating at a loss over the entire 10 years prior to closure. And similarly with their cash flow. I think that surprised us. We assumed that we would start off maybe in year 8 or 7 as still having positive operations, and that wasn't the case. And then you get to the point that Jeff has mentioned where you kind of hit a hill of sand and you can't recover from those sustained losses year over year. So that one really hit home for us. I don't know, Jeff, if anything else surprised you.
I guess I wouldn't say surprised, but I was gratified in some of the findings. We've said to clients for many years that top line revenue growth is one of those key indicators of organizational health. It's really difficult to sustain a healthcare organization if revenue's growing or, in fact, not growing. But if it's growing at a very, very modest level or not growing at all. And that is one of those warning signs that, the organization is at risk. It's not doing things that it needs to do to be long-term viable. It was very gratifying to see that the data support that and validate that. And I think the other thing I would say, our hypothesis when we started the study was that there would be a significant set of variances in the pre-closure trajectory of those hospitals that closed versus those that didn't. And for the most part, I think we found that to be very true. I think the one place where it gets a little muddled is that top performing quartile of closed hospitals that on some of these metrics approached or even equaled the median level for open hospitals, yet these organizations still closed. And I think that's, an interesting finding that not all of the hospitals that closed neatly fit into what we think of as being a high risk or elevated risk organization. And I think that's something that it's important to be aware of. There's some other X factors out there that have not captured by the data that obviously factor into that decision and that reality about closing.
Yeah, it's super helpful, Jeff. And there's a question that came in that really dovetails into that. For those hospitals that are still up and running today, how can they measure their risk profile?
It's a great question. I think one of the things we would like to do with the next phase of this study is provide some risk thresholds for organizations and some benchmarks. So when we look at that critical decision period, the 8 years or 4 years prior to closure, providing some benchmarks that and some comparisons that organizations can look at. So, for instance, I think it was if I don't have this wrong, the trend for operating cash flow margin for closed hospitals in that critical decision period, 8 years to 4 years prior to closure, that trend was a negative 20% compound growth rate, i.e., decrease. And clearly, if your operating cash flow is decreasing, that would be a key consideration. So I think in the next coming weeks, as we get towards publishing this data, we should have some available benchmarking and risk thresholds that would be part of that publication and may be helpful to hospital management. Julie, I don't know if you'd add to that.
That is exactly what I was thinking. And the other component that we would be able to provide is to dive a little bit deeper in that data and say, oh, you're a critical access hospital and you have X, Y, and Z. Well, let's compare you to that type of a hospital. And we could actually take your hospital data and compare it to others of similar size, designation, or whatever else might make you different than others.
Great. There's another question just came in. For hospitals that avoided closure by integrating into a system, is there data on how performance improved post-merger or acquisition?
So
great question.
Great
Go ahead,
question.
Julie.
We do have data around which of the hospitals that we studied have integrated with the system. We have not said, let's look at it post-integration, but that's definitely something that would be very interesting for us to do. Would love to do that.
And also look at the relative performance of hospitals that closed that were in systems versus independent. Are there some key markers that differentiate those or et cetera? But it's a great suggestion and something we can look into further.
Yes,
Awesome.
When we looked at days cash on hand, that was one of the things that that's when we clicked that lever so that we could see whether or not the cash was being swept by a partner versus independent. So we can look at that. That would be great.
So I think we have time for one more. How can hospitals begin to utilize the findings of the closure study?
Well, I guess what I would say is we do intend to provide some guidance and measurement around risk thresholds. i.e., what constitutes a high risk, high strategic risk organization versus one that's maybe more moderate risk and one that's low risk based upon some of these results. So that would be one way an organization could look at those thresholds and say, we fit within this box or we fit within that box. I think there's some in-depth work that we would do and likely make part of some of our consulting work to really dig in more detail. If folks have a unique set of every hospital is going to be unique, but to really dig in more in depth. So I do expect that there'll be some resources we will have available to anybody in the industry to help them evaluate risk going forward and understand based upon this industry experience of 15 years looking at closed versus open to really put some of those thresholds out so folks can get a clearer idea, an objective idea based upon industry performance and results of where their risk profile lies.
Yeah, fantastic presentation. Thank you both so much for bringing this information. It was really valuable, especially as we think about evaluating that risk in our smaller rural hospitals, right? We know there are ongoing challenges. We know that map of 200 closures is likely to be greater given the OB3 implications, particularly starting in 27. But whatever we can do to keep healthcare local and keep care in rural communities, I think is all of our shared mission. So at this point, we've got a little bit of time. If everyone would return back to the event lobby, you can then join our next session, which will begin at the top of the hour, and that'll focus on performance improvement and strategic options. So once again, thank you so much to Jeff and Julie for this presentation, and we look forward to seeing you all or chatting with you all in a few minutes. Thanks so much.
Thank you.
Thank you.